Okay, so as people are arriving, my name is Olive Cokerman for the Network for Improving Quality of Care for Maternal, Newborn and Child Health. Welcome to our webinar today on transforming care for small and sick newborns. This webinar is being co-hosted with WHO, UNICEF and the partners of the Every Newborn Action Plan. So next slide, Ornella.
Oh, it's locked.
Perfect. Okay, so this is part of a series that's ongoing over the next 12 months or so. The objective of the series is to accompany the learning and experience in implementing the WHO standards for improving the quality of care for small and sick newborns in health facilities and the related guidance for their implementation. Next month, we will have a webinar on the new evidence on kangaroo mother care. And in August, we will share country experience on nurturing care for every newborn. So today, on the next slide, we set out our speakers. So firstly, in part one, we're going to have presentations from Dr. Ornella Lancetta, Medical Officer of WHO Geneva, on expanding human resources for the care of small and sick newborns, on the recent publication of strategic options to address gaps in human resources for newborn care. Then we're going to hear from the Ministry of Health, Kenya, and the University of Nairobi. We're going to share their experience in developing a neonatal nursing cadre. So we're very happy today to have Dr. Laura Angweni Bonoreri, Head of the Division of Newborn and Child Health at the Ministry of Health, Kenya, as well as Dr. Joyce Tibet, Lecturer at the University of Nairobi. And we will then have a 30-minute Q&A session facilitated by Dr. Gagan Gupta, Health Specialist in UNICEF New York. So over to you, Ornella. We look forward to hearing all the presentations.
Thank you, Olive. Good morning, good afternoon, good evening to all of you attending this seminar. And I'm very pleased to discuss with you over the next 15 minutes how we can expand the human resources for the care of small and sick newborns, and specifically the strategic options that we have to address the current gaps in human resources for newborn care. And we all know that over the past years, a lot of work has been done to gather evidence on what are the intervention to address the huge burden of newborn health. And we have developed a number of strategy and documents to address the needs of newborns, but certainly, and we have the targets for the first time to 2030. But there's been a progressive recognition of the importance of investing on the human resources if we want to reach those targets on neonatal health and survival. And within the human resources, certainly midwife and nurses are a critical group. In general, there's been a number of estimates over the past few years, the Global Strategy on Human Resources for Health in 2016, but also the State of World Nursing last year, and again the status of the report on the status of midwifery this year, all show that the gaps in human resources are huge, and it is estimated that the global shortage on nurses and midwives to reach the SDG by 2030 is around 7.5 million, which with a large majority is in low middle income countries. And within this global shortage, we have also the shortage of for our population group, the newborns. And to look really at what are the challenges, the gaps and the challenges that we face in human resources for health to ensure quality newborn care for all newborns in low and middle income countries, we have conducted a scoping review a couple of years ago and published last year. And this scoping review have identified a list of challenges that are summarized in 10 groups. in these slides that are going from a lack of human resource for health data monitoring, but also poor pre-service education, lack of access to guidelines and the continuing education for those nurses and midwives that are allocated to neonatal services, insufficient distribution of healthcare workers and heavy workload in neonatal units, which also leads to poor retention, absenteeism, rotation of experienced staff. That so all of this combined with the poor work environment, low salary, and limited supervision creates a situation in which the healthcare providers deployed in the neonatal facilities many times are facing have low morale, have more motivation, low motivation, and are in general not very satisfied on their job. So, and finally, the weaknesses in policy, governance, and leadership that have been identified in this review on neonatal health challenges, but are the same type of challenges that we find more in general among the workforce, nurses as well as midwives. And these challenges, the reports that you see on the right part of the slides highlighted that we need to invest much more on education, jobs, and leadership for this for the workforce. And if you look specifically at the quality, what is needed to ensure quality of neonatal care, it is recognized that we need the teams of care workers with neonatal care skills. And teams means not only the nurse midwives, but also the medical doctors need to have those competencies that are required in order to provide quality services. And because there is also a clear correlation between the number of care providers and the mortality, neonatal mortality as well as stillbirth mortality. And specifically for small and sick newborns, we know that 1 to 4 is a good a good number for special neonatal units, 1 nurse per 4 babies, I mean, and 1 is the gold number for the NICUs. There are a number of critical areas for newborn care that we need to address, and they are going from transforming the education and in-service learning to mentoring and supporting supervision, but also empowering the staff, improving the working conditions, and putting the care workers in the position of being able to partner with families to provide better services. It's important to consider also the fact that we cannot look at the newborn, at the workforce for newborn health in isolation, but this needs to be considered within the overall human resource plans of the countries. And this is why we have worked a bit on looking at which kind of strategies we should think or could be appropriate for newborn health within the overall human resources for health strategy. And this is why we developed that document, which provide a kind of framework to look at the strategic options that countries can choose to transform the human resource policies, with thinking also about better quality care for all newborns in order to reach the SDGs. And we developed this document starting from a discussion with actually the users, with the nurses and the care providers from countries that were attending the COIN Africa meeting in Rwanda in 2018. And then we, of course, we did also the background work, as I said, the scoping review on human resource challenges. We also looked at the programs and strategy in different global strategy, but also country programs in order to collect lessons that could be used for guiding countries. And then we developed the document also through expert reviews. And so we came at 10 possible strategies that country could choose, or better if they use all of them, but they can also select those that fit better in their programs. So 4 of these strategies are focusing on the training programs that countries can decide in order to optimize their human resources for health cadres, but also to invest in new cadres specialized on newborn care. And then 5 strategies are more looking at the type of action that are required for provision of better neonatal care that we will describe better later on. And then one global, and a series of global action that are under the global support to the countries. And for each of these strategies, we have identified the rationale, interventions or actions, and then some country examples. So for the training options, which are really very, very important, we are not saying that the countries have to take all of them, but they can take some of them, or they can take them in sequence, if you like. So the first one is to improve and standardize the neonatal content and the curricula, and also the competence development in the pre-service programs, because there is a recognition that nurses, the current training programs are often weak in terms of neonatal care, not updated with the new evidence. And this it goes across the different cadres. It includes also sometimes the medical curriculum. Then to build, the second strategy is to build the capacity of existing healthcare providers, and there are a number of programs that can help in that. The third strategy is to upgrade existing cadres, but with the specialized neonatal training, which gives additional qualification, certification. This could be I don't know, topping up programs of 3, 6 months or 12 months, but certified. And finally, the fourth strategy is to create and train a new specialized neonatal nurse cadre. And I know that some countries are really embarking in this as they are expanding their services for neonatal care, particularly. Yeah. Then the other 5 strategies that you can see here are focusing more on those type of actions that are required to improve the quality of the provision of neonatal care. And the first one is standardize the level of neonatal care provision, including the referral system, because many times there are no standards, and it's not very clear what is happening in the different levels of the system, and the standards of care are not well defined. The next strategy is to establish really the strategy for the health workers recruitment, well-being, motivation, and retention. The next strategy is more focusing on the effectiveness, staffing ratios and skill mix at the local level. And I know that it's very challenging, but it's important to at least to define what is needed and try to cover the gaps. And then the following strategy looks more at the national and strengthening the national human resource planning, the policy and regulations for specifically for the development and the management of neonatal health services. And this is a chapter that is often missing within the human resources for health plans. And then the 9th one is of course very fundamental, which is the financial part. It's important to allocate the funds for capacity building, but also for supporting the neonatal care in general into these funds have to be allocated in the national budget for human resources for health. At global level, we need to continue with the promotion of global strategies and the collaborations, but also to assist in accountability, leadership, and governance for the human resources for newborn care. And we can do that also by integrating innovative multi-country research, because still research in this area, when human resource applied to the neonatal service, is not that much developed. And of course, we think it's very important to promote networking, learning networks, so countries can learn from each other. And I'm happy to say that this year the World Assembly passed 2 resolutions on the health workforce. One more on that applies to all the healthcare workforce on protecting, safeguarding, and investing in health and care workforce, more on the aspects of health employment. And the second one is a World Health Assembly resolution more specific on strengthening nurse midwifery, which recommends policies for better education, jobs, leadership, and service delivery that should empower the nurses and midwives to have a better impact on the population health outcomes. So all of this is these recommendations that we find in the resolution are also very much in line with what has been found in the State of World Nursing Report last year and in the State of World Midwifery Report this year. So is really an answer a bit to this to those reports. And for what concerns newborn health strategies for human resources for health strategy for newborn health, we think that we can be more strategic, we can be more systematic, and we can start by really counting and doing assessment, priority setting, and plans for this area of work, especially because there are specific targets on expanding the neonatal services, that expanding the coverage, but also the quality. And then having done this assessment and priority settings, we can start to implement them with the idea of trying to reach, cover the 40% of the gap by 2025, and then moving to covering the gap at least of 75% of the gap by 2030. And we hope that by doing that and trying to follow those steps that has been identified by this document with the support of the international community as well, we will be able to accelerate progress for all newborns. So there is hope. I mean, we think certainly for reaching the SDG targets, we need to invest on human resources. Has been recognized is fundamental, and there is no way that we can get out of this. All countries can take steps independently of where we are. We know that there are options that the countries can take, steps that they can take to strengthen their human resources. Capacity building is fundamental and should start in the pre-service, and then they can continue, of course, in in-service learning and in coordination with career development, so the health workforce doesn't get demotivated. And there are also important options that we need to take into consideration for improving service provision at the different levels of the health system. And of course, globally, we need to continue our advocacy and action in order to build country leadership and capacity on newborn care. And if we are really investing in human resources for quality newborn care, we can not only contribute to better outcomes for newborns and families, but also we will contribute to strengthen the care system and build human capital. Thank you very much. And I hand over to our speakers from Kenya.
Thank you. My name is Dr. Laura Angwenyi. I head the Division of Newborn and Child Health at the Ministry of Health, Kenya. I'll give a brief overview of the status of newborn health in Kenya and hand over to my colleague, Dr. Joyce Jebet, to take us through the meat part of the presentation. So next slide, please. In Kenya, we have a very high rate of child mortality. We lose around 52 per 1,000 under 5, 39 per 1,000 under 1 infant mortality, and we lose around 22 newborns. That's our neonatal mortality rate. When you look at the total of children we lose who are under 5, A third of the children we lose are actually in the newborn period. And the leading cause of death in this period is birth asphyxia, prematurity, and neonatal sepsis. As a country, we've tried to put together priority interventions that address these issues. We do have our national policies and guidelines. We have policies that touch on how to communicate with the caregiver, how to the immediate care of the newborn, keeping the baby warm, breastfeeding the newborn, and also looking at that small and sick baby, provision of kangaroo mother care, and how to evaluate the newborn before you discharge them home. One thing that we are quite cognizant of is that when you have healthcare workers who are knowledgeable and skilled in taking care of newborns, coupled together with the correct equipment in the newborn units and in the delivery maternity units, so that that newborn could be managed correctly when they are delivered, we will reverse this very high neonatal mortality, and we strive to improve on that. So we go to the next slide, and I want to hand over to my colleague, Dr. Joyce. Thank you.
Thank you very much, Dr. Angwenyi. So I'm going to talk about the experience of neonatal nursing training program. And we move to the next slide. As Dr. Angwenyi has said, one of the challenges that we have is a high neonatal mortality, and this led to the need to be able to bring in or to be able to introduce neonatal nursing training. Previously, this training was captured generally under pediatrics and midwifery without much attention being paid to it. And gaps were identified in provision of care. For example, the nurses were not very competent in providing specific neonatal care nursing services to babies. So that's why this led to that aspect of training specifically in neonatal nursing and paying more attention to neonatal care, with the effort, of course, of improving newborn survival. We move to the next slide. So I want to give an experience of how we teach at the University of Nairobi. We cover neonatal nursing in 2 areas, undergraduate studies and also for the postgraduate studies. So for the undergraduate studies, neonatal nursing is covered under pediatrics, but there's a specific subsection for neonatal nursing, and also in midwifery and obstetric nursing, the students also cover that. And this is where now they do the clinical rotation. So the time allocated is 30 hours for theory and 80 hours for clinicals, specifically for the neonatal nursing. And for the postgraduate students, we have the midwifery students, and we also have the pediatric nursing students who, these groups of students are taught separately, and they rotate in the clinical, in the newborn unit specifically. Each covers 60 hours in theory and also in the clinical rotations. And this include clinical assessments just to ensure that the students are able to gain the competence and confidence. So other universities, they have different modalities of delivering this content of neonatal care, but most on average is taught around 60 hours, which are covered in under postnatal care courses. And this could also be offered in form of overview lectures and tutorials. And we have a specific course that has been, is currently being maybe underway, or it has just started in some universities, but Bachelor of Science in Midwifery. And this course offers specifically 120 hours for neonatal nursing. Next slide. So we also have specialized training programs that offer neonatal care, and one that has had over 6 cohorts graduate is the Kenyatta National Hospital. So they offer training for nurses who already have a diploma, and they do a 1-year course on neonatal nursing specifically. And we also have a neonatal nursing critical care, which is offered in one of the hospitals, in Nairobi Hospital. So they have a nursing school, and they are in their 3rd year of offering this specific course. And then we also have another institution. It's a private institution. It offers a diploma in pediatric nursing. Again, it is a higher diploma, meaning these are already nurses who have their diploma they have graduated with a diploma, and they do a 1-year course in pediatrics. And under that, they have neonatal nursing, where they rotate in the newborn unit for 8 weeks. Yeah. To improve also neonatal nursing, we have other neonatal training courses that are offered in the country. Just to give a few examples, we have a HBB course, ETAT, EMOC training and stable. We also have workshops and conferences that are organized to be able to help in continuous professional development. And one of the key contributions that has come in from the neonatal program is the formation of the Neonatal Nurses Association of Kenya. And this Association of Neonatal Nurses brings together the neonatal nurses, where they have discussions and they have seminars to learn and encourage each other. So because of that, we had our our second African Neonatal Nursing Conference last in 2019. This conference was hosted by the University of Nairobi, together with the Association of Neonatal Nurses and the Council of International Neonatal Nurses. And during this conference, we realized that people were actually very keen and very eager to participate in neonatal nursing courses and programs. And then we move on to what are the next steps that we are doing. In the pipeline, the University of Nairobi School of Nursing is in the pipeline of establishing a neonatal clinical fellowship. It is intended to be a one-year program that has a lot of clinical approach, and we hope to maybe enroll people who already have a master's in midwifery or a master's in pediatric nursing, and just for them to be able to have more information on neonatal care. And then we also have neonatal training, short courses, like we held a course on HBB, and also we have some form of a specific aspect on neonatal training, but a clinical approach. And then we have webinars and seminars. We held our first seminar in the month of May, specifically on neonatal care, and we have this every 3 months. Yeah, okay, so thank you very much.
Thank you so much to the wonderful panel of Dr. Ornella, Dr. Joyce, and Dr. Laura. So we have enough time for half an hour for the questions. And I think just to set the ball rolling, I would like to really congratulate the organizing team for picking up this topic at this moment, because given the fact that with COVID, we have already depleted a lot of human resources in a workforce which was already on the short side of the supply. And the very fact that the COVID response will entail a lot of stress on the health workforce and will require a lot of shifting of probably the workers more to the management of the COVID patients, especially in the countries which are grappling with a huge caseload. So I think bringing the focus back on human resources for the newborn care is very timely and very appropriate. Now, just to set a few comments, it's important to look at the human resources for the newborn care unit as a whole and not only focus on one aspect of the human resources. For a well-functioning newborn care unit, it's equally important to have the support staff. It's equally important to have a data person. It's equally important to have a nurse, and it's also important to have the adequate number of doctors. When we are planning for a newborn care unit, often what happens is the first thing that comes is the equipment, and second thing that comes is the infrastructure. But what gets left behind is the proper planning for the human resources. And these things have to be all done simultaneously and not sequentially. Otherwise, in many places, as we see, the equipments come, you create a building, but there are not enough human resources to run them. And often in the evening and the night hours, the human resources get even further depleted. So the first thing probably which is important is to make sure that in the planning and the budgeting, we have provision of adequate number of human resources for the newborn care unit, starting from doctors to nurses to the support staff to a data entry operator. Once these provisions are budgeted, then the second step is to see at the human resource policy of the country, so that you can attract these people, retain these people, and if required, redeploy these people. Now, in terms of attracting the right human resources, you won't get an ideal world. Many of them have not been trained in the newborn care when they joined the newborn care units. And I will give you experience from India. When we started the newborn care units, many of the nurses whom we hired, they were not expert in the newborn care because the newborn care was not functional at district level where they were trained. And they learned while working in the newborn care units. So it's important that as we are developing the cadre of neonatal nurses, we also look at making adequate provisions for on-job training of these nurses. And once the policy and the budget is there, it's very important to factor in these dedicated positions. Otherwise, you start a newborn care unit with a lot of paraphernalia, but you don't factor in for human resources, and then the hospital tries to pull the nurses from different sources. And already they are short of nurses and you don't get enough of them. So it's important to you factor it and then give them a proper salary, including flexible provisions like walk-in interviews, the difficult area allowances, and some additional incentives, which we can discuss as we go forward. But to start with the first question, it's for Ornella, and that question is from Susan. The recent publication of IKMC studies advanced the concept of mother NICUs. Could you discuss the ways that countries will respond to provide immediate postpartum care to mother newborn couplets in NICU settings? Over to you, Ornella.
From the point, yeah, thank you for the question. I think the issue is to build the capacity to incorporate this new recommendation, let's say, in the policy and practices of the facilities. So and to build the capacity, the confidence of the care providers in keeping in partnering with the mother and the family, so they can minimize the separation of mothers and babies starting from birth. I think it's really a bit of a paradigm shift in first of all in how we provide care actually, and we can start immediately with the existing care providers. We probably don't need additional care provider for that. Yeah, but it needs to be incorporated in the policy, in the and also in the curricula. I mean, people need to know why the care providers all. I mean, they need to, from the doctors to the midwives to the nurses, they need to know why it's so important to minimize this separation, to keep mothers and babies together as much as possible. And this is true at the delivery, and then if the baby are sick in the neonatal during the process of care. Yeah.
Right. So the next question is to all the panelists, if you want to put your thinking through on that, like how can the practice of rotating nursing staff through different clinical areas from delivery to orthopedics to adult medicine can be altered to allow development of expertise in the newborn care? Maybe you can start, Ornella, and then we can listen from the country teams as well, Dr. Laura and Dr. Joyce.
How to alter the rotation?
Yeah, how to stop the practice of rotation?
The rotation, yeah, that is another thing that needs to be discussed locally, but also to be, let's say, to become part of the policy. I know that everywhere, this is an important issue because providing care for newborns require really to gain the competencies. It's really a pity when we train people become competent and then they are rotated. So as to become policy for this type of services, rotation should be limited. I'm not saying stopped, because people should have access to other to other services as well, but it should be made in such a way that is not impacting, the rotation is not impacting on the quality of services. And it can be done, for example, by alternating the service in the neonatal unit with the service, for example, in the follow-up. Because I know that neonatal nurses are often under stress The work is very demanding for many reasons. First of all, it happens 24 hours a day, and also it's not easy. Many cases, etc. But we need to create the conditions for better working conditions, so people, are not too overwhelmed. And one type of rotation is that is still within the neonatal services, if you like, is to give a bit of rest, let's say, to the nurses, is to be able to move from the inpatient, units to the outpatient time to time. So because it's less heavy as a type of work.
Okay, thank you so much, Ornella. Can you hear me, Ornella?
Yes.
Okay, so let's also hear from Dr. Laura, because I think as a senior program manager, this is something which you must be grappling through often. So what is your view on this?
Thank you. Yeah, it's something that really poses challenges because you build skills and then they are transferred. And I think from where I sit, I've come to the realization that it's a problem that needs continuous addressing. So one thing I've learned is that in the national referral and teaching hospitals, the staff in the newborn units tend to remain the same throughout because of their skill level. But now when you go to the lower level facilities at the counties in the districts, you find that that's where most of the rotation occurs. So one thing we are looking at is to try and embed on-job trainings so that whenever staff are rotated into the newborn unit, the skills transfer from the ones being transferred out to the ones being transferred in. And then at the national level, we try to enhance on our support, supervision, and mentorship to ensure that that the correct management and correct service delivery is accorded to the newborns. So it's a challenge. We don't have the solution yet, trying to come up with different models, and I'm sure in the next course of years, we will have a solution to it. Thank you.
Thank you so much, Dr. Laura. And from our experience in India of setting up of these nearly 1,000 newborn care units, one thing which we realized was it's important to have the staff earmarked for the newborn care unit. So we had a provision of 4 doctors, 15 nurses, and 6 paramedical staff to support the other services, and 1 data entry operator. And then a very strong monitoring by the district authorities and the state level to ensure that this rotation does not happen from the newborn services to surgical or the orthopedic side. But as Ornella said, we can rotate them between the newborn and the follow-up of the newborn care, and in the labor room for the newborn care corner and the newborn resuscitation. And when you have these nurses rotating between the labor room, the newborn care unit, and the follow-up OPD, it also helps to improve the skills of resuscitation in the labor room staff. And it also helps in terms of de-stressing these nurses by taking them out to the labor room and the follow-up OPD. So having a earmarked staff for the newborn care units is also something which has been very helpful. And in India, when they hired these nursing staff, initially a lot of these were contractual positions. And when they were regularized, they moved from one district to another. But even when the transfers were done from one district to another on regularization, they were given the posting in the newborn care unit only. So I think one of the things is a high level of awareness and commitment at the level of senior managers and policymakers is also one thing which probably facilitates this. But we also have a lot of people from the audience. We have Asha, we have Fatima, we have Kaninika from India. Maybe some of you can put your experiences in the chat box as well. So meanwhile, we can move to the next question. And that question is for the Kenya team. Does Kenya have lessons to share on how current strategies have helped on rural-urban distribution of nurses? And that's something which is a big problem, especially you find that those districts which are away from the capital and the headquarters, getting the human resources there itself is a big challenge. So Dr. Laura or Dr. Joyce, would you like to come on that?
I'll let Dr. Joyce answer that. Dr. Joyce.
Okay, thank you very much. So one thing that has been done is, of course, most of the time people want to be in the urban area compared to the rural area. But one thing that has been done is there's flexibility where nurses are allowed to switch with one another. So they get someone who is willing to move from an urban setting to a rural setting or from one county to another. So there's that flexibility of allowing them, and that could also be a way of helping to motivate. Thank you.
Right. Thank you so much. And the question from Joe is, all panelists, how do we retain specialists within the public sector? A lot of nurses in public sector after gaining specialist training tend to transition to private sector. So her question is more about how can you make public services more attractive and keep them to the par where the people don't move from public to private, because a lot of investment on trainings is done by the public sector, but the advantage is reaped by the private sector. So any one of you, the three panelists, it's open for all.
Maybe I could go first. One way of trying to retain nurses in the public sector is improving the work environment. One of the challenges of our public sector is the work environment may not be very friendly. The workload is so high and the staffing is low. So if this could be improved, it can help. And also motivating nurses, particularly in terms of remuneration, that can help in reducing that movement of nurses moving from public to private, or sometimes even moving from this country to other countries abroad. Thank you.
Yeah, I fully agree with you.
Right. And also, like, what experience which we had was, if you keep the salaries in the public sector slightly higher than the private sector, we also had nurses leaving from private sector and joining into the public sector in India. But the thing is, you have to take them when they're available. Often the systems are so bureaucratic that when people need job, the vacancies are not open. So having things like walk-in interviews, keeping the salary scale on the slightly higher side, providing difficult area allowances and incentives, these are also some of the things that help. There's another question from Joe that's regarding the role of biomedical technicians in the team. Ornella, would you like to go for that?
The role of biomedical technicians.
As a part of the human resource planning.
They are, yeah. They, of course, they play a role. I mean, for newborn health, we need to consider all, but 90% of the care actually stays. We don't have to forget that a big part of the time the newborn is in the hands of nurses and midwives. So that is why we are focusing very much on those. But of course, we need also other cadres that can help to provide the quality of care that is required, especially at the higher level. Yeah.
So, Dr. Laura, how is Kenya handling the issue of biomedical technicians and the equipment breakdown? Because the easiest thing is to get an equipment to a unit, but the most difficult thing is to have a downtime with the equipment repairs. And some of the countries have also tried to train the cold chain mechanics into the warm chain repair, like the repair of the warmers and all. So, and also at many district level, they have tried to have a dedicated person, if not a biomedical engineer, but someone who is qualified to address the small issues, and then it can be escalated to a biomedical engineer who can be at a regional level. So what has been your experience in Kenya, if you may want to share?
Yes, I could share a brief about one thing that we are doing together with one of our research institutions, KEMRI. It's called NEST, the Newborn Essential Solutions and Technologies, which is a bundle of care offered to newborns that looks at the healthcare workers who are trained, they are skilled, and they are provided with that training to care for the newborns. But also in the same training, we do have the biomedical technologies who go to train the facility biomedical technologies on how to repair and take care of the equipment in the newborn unit. This is because many a times we did find that the incubators and the equipment used in the care of newborn conditions, once it gets spoiled, there's no one there to repair it. So most of these were taken to a store and thrown away and new equipment procured, which is very expensive. So when this newborn essential solutions and technologies was introduced, it's currently being implemented in 13 county referral hospitals. And we intend to scale it out to the country. What was found is that you find a very small part is what is needed for an equipment to work in the newborn ICU or in the newborn unit. And it proved to be a very cost-effective and cost-efficient way of working together, healthcare workers with the biomedical technology. So moving forward, there'll be a critical resource for us who program for newborns and who want to ensure that how the newborns are run, they are run in a way that will provide quality of care to the newborn. And quality of care means that the equipment that is used is equipment that is working and functioning properly. So biomedical technologies are a very critical human resource in the newborn unit and for newborn health.
If I may add, I think also is important for all in the team to be aware of how the materials is working. Sometimes, the materials, the equipment is delivered, but there are no explanations. So there is no capacity building on how to use the materials. I've seen babies who completely dressed to be put in incubators that are not working, but incubators that are potentially working, but are not put, not linked to the power, to electricity, because nobody knows how to use the incubator and things like that, or because the alarm of the incubator is always on due to lack of I don't know, water or something like that. So it's very important for not only to have the technician available, which is a good option, but it's also for everybody in the team to be able to have a minimal knowledge of how the materials should be used and maintained as well.
No, thanks, Ornella, for this. And basically, what's very important is when the equipments are procured, they should have a proper annual maintenance contract. Number two, the district should know whom to reach out in case of a breakdown, a proper orientation of the district teams when the equipment arrives in the unit. And it will be always better if at a district level, someone is given the basic training of addressing the small faults. And if the issues are bigger, then a regional level kind of a hub where these equipments can be sent. What also helps is having a buffer stock of equipments, because sometimes the repair time is quite long. So it's always better when you're planning a newborn care unit, plan for around 20 to 30% buffer stock, so that when there's a breakdown of equipments, the new equipments can replace on the buffer stock, while the equipments which have more issues can be taken to the central store for repair. And we also have some interesting examples from Sierra Leone in the chat box, which Asha has put. And we also have Kim Dixon, who is our newborn team lead, and she was also in Sierra Leone for a long time. So any one of you, if you want to please contribute, you can speak out or you can speak in the chat box. So I think the next question, Ornella, is for you, is regarding what qualification would you recommend for the cadre of the newborn nurses? And do you have some country examples of creation of that kind of a cadre?
It's a difficult question because it depends on the development of the system of the country. Ideally, you would like to have neonatal nurses, some countries are embarking in. So you have a program of neonatal nursing. We heard about, from the experience of Kenya. We know that courses, specialized courses in neonatal nurses being done are available also in Rwanda, in South Africa, in Morocco, and other countries. So These nurses are of course ideal for the care of small and sick newborns, but for countries that are in the phase of transformation, let's say, they don't have yet sufficient number of midwives or nurses for in the phase in which they're expanding the services. I think I can see that it's easier to upgrade the existing care providers or to provide, these top-up courses more than as a first phase before embarking in creating a new cadre. I mean, there has to be phased up a bit planning, this new cadre for the intensive care unit of the biggest neonatal units, but thinking also the strengthening the competencies and the number of human resources in a smaller neonatal units. Yeah, so that is, people have to, this is why I was saying the baseline is very important to assess where we are in each country, where we are, how many are, where we want to be, and to see what the gap is, and what is the capacity of the training institutions to cover those gaps. Training institutions and with these different strategies that we can choose in order to cover the gaps. I mean, it's not one recipe for all, basically. It needs to be based on the need assessment.
Thank you. Thank you so much, Ornella. And I think one of the important things is, in an ideal world, it would be good to have a cadre of neonatal nurses. But till we reach that point, it's important that we also make use of what we have at hand. And the first step would be is to make use of the existing nurses and train them in the newborn care in service. And if we have a limited number of neonatal nurses, they can be made as the in charge of the newborn care unit. So the overall in charge of a newborn care unit can be a neonatal nurse, and then she can be supported by 12 to 15 nurses who are supporting the nursing, and they are trained into the newborn care and try to achieve a nurse bed ratio of one nurse not looking at more than 4 beds. And also it's important to have this ratio in the night shifts, because often in the night shifts you will find the nursing numbers is reduced to half, and that's the time when the babies can deteriorate, and in the morning you will find babies not in the good shape. So these practical solutions we will need to have a look. And there's a very good comment from Kanika from India, where she has said about the newborn aides and the experience which they had in West Bengal in India of having newborn aides working with the nurses to support them and to take some of the routine things like bed making and the other things. And also the engagement of mother in the care of the baby can also help reducing some of the load on the nurses. So the most important thing is, when we plan a unit, we plan for the human resources as well, not only just equipment and infrastructure. We make provision of the nursing staff in ratio of the beds, and then we try that these nurses are trained. If possible, you have trained staff, that's easy, but it's not that practical. So you will need to train people when they are on the job. So these are the things probably, and then make sure that the people whom you train, they don't leave and go to either private sector or are deployed in a surgical or an orthopedic ward. So these are some of the things as program managers, you may think holistically. So if there are any other comments or any questions, Olive, just one last check with you, anything which you feel needs to be still flagged?
Thank you so much, Gagan. That's been fantastic question and answer session. No, I feel like you've really got through the questions that have been coming through. Thank you so much to all the participants for sharing those questions. And so if there are none other coming through right now.
Oh, sorry, you wanted to be there. Yeah, sorry.
Oh, that's great, Ornella, thank you. Okay, so just to say, that's fantastic. Just to say, Save the Children and partners are hosting a community of practice on this topic. It will be hosted in 2 weeks' time. So you'll receive those details, all the participants from the webinar today. We will share with you the recording, the presentation, and details about that community of practice. And Also, we have upcoming webinars in this series. The very next one will be on July 21st. And this is on the issue of immediate kangaroo mother care. Many of you may have seen the publication recently in the New England Journal about immediate kangaroo mother care, as opposed to the current WHO recommendation, which is to wait until the stabilization of the baby. And so the research team will be joining us for a webinar discussing the impact of those research findings and the development of new WHO guidelines accordingly. So you can hear more about the series, just follow the links, stay engaged. We share everything on our website, on the network website as well. Thank you so much for joining us today. Thank you so much to the speakers for your very clear and informative presentations and sharing many insights that I think are well appreciated by the audience. And thank you to the participants for joining us and sharing your questions. So unless there's any further questions, we just say goodbye for now and hope to see you all again on July 21st.
Thank you, everyone. And we give you 5 minutes back in your life to you. Thank you.
Bye. Bye-bye.
Great.
Thank you. Bye.
Thanks so much.